Can we start?
Am I audible?
Yes, sir, clearly, and you are visible as well. Sir, it's 7:1. Shall we start?
Yes, yes. Okay, we can start.
Start the recording.
Okay. Good evening, everybody. My dear students, today we will have a case discussion. Is it that any one of you have brought a case? Then we can discuss that. Otherwise, I have brought a case so that we can discuss that case. Anybody who has brought a case? Any one of you? Okay, then we will start with the cases that I have brought. Okay, can you see the slide?
Yes, sir. Yes, sir.
Any volunteers to discuss the case? Any volunteers? All of you should try to volunteer, because by volunteering and discussing the case, you will gain confidence. And when it comes to the examination, you will be ready to discuss any case. So any volunteers? Is Dr. Pallavi there? From UN Mehta, Ahmedabad? Soumya? Saurabh? Ramesh from Lilavati? Dr. Wadia? I think I heard the voice of Navjot. Is Navjot there? I thought I heard Navjot telling something. Are you there? Am I audible? Am I audible to you? Anybody who would like to?
Yes, sir, you are audible, sir.
Then why can't one of you discuss the case? Any one of you can do it. Anil Kumar? Gaurav from Trishur? Ranjit, are you there? Ranjit? Ernakulam, Kochi? Anybody can do that. Is Navjot there? Navjot from PGA Chandigarh? Dr. Rahul, would you like to discuss?
Yes, sir.
Okay, you start.
So patient 29 years old female with complaints of exertional breathlessness since 3 months, tiredness since 2 months, one episode of giddiness on exertion 1 month ago,
Okay.
edema of both lower limbs 7 days.
Okay. By looking at this, let us discuss the first point, that a 29-year-old female has come with few symptoms. So, when you see the patient, you should start thinking, 29-year-old female, what are the possibilities?
So one possibility, she's first we need to differentiate this from the respiratory from cardiac. So in cardiac, the first possibility is mitral stenosis can
rheumatic heart disease. In a 29-year-old
heart
female, you must always,
Yes.
especially coming with exertional breathlessness, you must always think of the possibility of rheumatic heart disease. And in females, mitral stenosis is a possibility. Okay, what? Rheumatic heart disease. What else?
Yes. Then other is like other valvular involvement like aortic stenosis also can be kept in mind, sir.
In females, do you think the aortic stenosis is that common?
No, sir, it is not common, but
Aortic
considering
stenosis is
exertion,
a disease is of a male patient. Okay, right. Aortic stenosis, you mean congenital aortic stenosis, like bicuspid aortic valve. Okay, right. That can also be considered, but maybe slightly lower in the list. What else?
uh,
Any
sir,
others can also join. Anybody who would like to give comments about the possibilities that you should think about? 29-year-old female, when you see a female, especially in the examination hall, what are the possibilities you should think about?
So
Why the
cardiac
heart
heart disease.
Yes.
Cardiac heart disease.
congenital heart disease. Yes.
Which congenital heart disease?
Top.
Sir,
Yes, okay.
congenital heart disease like ASD or
Yes,
VSD
yes.
with Eisenmingerization can also present like this.
No, but since the symptoms are only 3 months, I think you should
Yes.
avoid thinking about BST, because if the large BST, they will be symptomatic from early childhood and they will develop into pulmonary arterial hypertension, Eisenmenger syndrome. But AST is a possibility. AST patients can become symptomatic in the third decade of life. What is the main difference between AST and VST and PDA? As far as the
Sir,
shunt is concerned, what is the main difference of ASD compared to VST and PDA?
Sir, ASD presents later, sir, as compared to VSD and PDA. These patients present earlier.
No. My question is, what will happen to the shunt in a patient with large ASD, large VSD, large PDA? What is the behavior pattern of shunt as the age advances?
So as the age advances, the flow from the left to right will increase because the pulmonary vascular resistance falls as the child grows. Immediately after the birth, gradually the pulmonary vascular resistance will decrease. So gradually flow will increase, and then the patient start presenting the symptoms. In VSD and PDA, both pressure as well as pressure and volume is transmitted to the systemic circulation, pulmonary circulation. So they develop pulmonary hypertension earlier. So.
They develop because of the communication, systolic communication in VSD and systolic and diastolic communication in PDA of the systemic circulation with the pulmonary arterial circulation will result in gradual and steady increase in the pulmonary vascular resistance and develop into pulmonary arterial hypertension. And these patients can present with features of Eisenmenger syndrome and right to left shunt, reverse to the shunt cyanosis. What happens in a patient with ASD? What is the difference in the shunt as far as the ASD is
Sir,
concerned?
ASD patients, in case of ASD, sir, more like volume is transmitted to the pulmonary circulation, and it is like pre-tricuspid shunt. So only volume is transmitted and pressure is not transmitted. So
Okay.
they take a longer time to development of pulmonary hypertension, sir.
I am not asking about the pulmonary arterial hypertension. I am asking you what will happen to the shunt. Is the we found that in VSD and PDA, as the age advances, and with the development of pulmonary vascular resistance, the shunt gradually comes down, and then it becomes even right left shunt. What happens in a patient with ASD? What happens to the shunt? Any one of you? In a patient with ASD, large ASD, what happens to the left to right shunt as the child grows?
So the shunt more or less remains the same.
The shunt.
Anybody else? Anybody else having any other thought process?
So shunt will keeps on increasing from left to right. So because RA is
Yes, you are right. The
more
pulmonary,
compliant than A, so the shunt will as
it's not the RI compliance that matters.
Sir, RV compliant is very prominent and
Yes.
it take more and more volume.
Yes.
So pressure is not generated that much.
Actually, in a patient with ASD, the shunt is decided by the compliance of the right ventricle compared to that of the left ventricle. as long as the compliance of the right ventricle remains much more, and I will be RV is a very compliant chamber, and as the compliance of the RV remains much more than the LV, there is always a possibility that the shunt will go on increasing. As the child increases, what happens to the LV compliance? Or as in adulthood, in a person who is reaching adulthood, what happens to the LV compliance?
LV compliance goes on decreasing, sir.
Yes, LV compliance comes down. Very good. LV, what is your name?
Dr. Harnish Bhatia, sir.
Dr. Anish Bhatia. Okay. So the compliance of the left ventricle comes down, and the compliance of the RV remains the same. And because of that, the left to right shunt through the AST will go on increasing. And so that will result in dilatation of the RV and dilatation of the RV. And then gradually, over a period of time, when the dilatation becomes more and more, these patients can develop some RV dysfunction. And also, there is a likelihood because of the dilatation of the right atrium, these patients can develop atrial arrhythmias. They may develop atrial fibrillation, and they may steadily deteriorate. This usually happens by third or fourth decade. That is why in a patient with ASD, the symptoms are quite late. It may be even in the fifth decade. So fourth or fifth decade or late third decade, the symptoms can happen. So here is a lady who is 29 years, so ASD can be considered. Very good. What else?
Sir, primary pulmonary hypertension also can be kept in mind.
Very good. Primary pulmonary artery hypertension can be considered because this is 29-year-old female. And from the story, do you have any clue that this could be primary pulmonary artery hypertension?
Exertional giddiness.
Yes, one episode of exertional giddiness. What does giddiness mean? Hemodynamically, what does the giddiness indicate as far as hemodynamic disease is concerned?
Outflow attack obstruction. Either a RV or LV.
It's a pressure overload. You need not use the word outflow obstruction. It's a pressure overload. Pressure overload.
Yes.
What are the conditions where the pressure overload can result in syncope? Can you mention few conditions?
So hypertrophic cardiomyopathy,
Hypertrophic cardiomyopathy, very good.
aortic stenosis,
Aortic stenosis, very good.
then
RVOT.
Even pulmonary embolism for that matter.
Pulmonary embolism is an acute episode because pulmonary artery hypertension. Pulmonary artery hypertension can have exertional syncope. Rarely severe pulmonary stenosis and severe systemic hypertension. Where patients with very high systemic pressure can also have sometimes exertional giddiness. So exertional giddiness is a symptom of pressure overload. So here, a lady, 29-year-old female, complaining of episode of giddiness on exertion. I think we have to think of a possibility of primary pulmonary artery hypertension also. Very good, yes. But then, how will you explain exertional breathlessness? Exertional breathlessness is a symptom of a right-sided disease or a left-sided disease?
More common in left-sided disease.
It's a left-sided disease. It's a exertional breathlessness is a symptom of left-sided disease. But then, when a patient is having exertional breathlessness and you are thinking of a right-sided disease, how will you explain exertional breathlessness in a right-sided disease?
Skeletal muscle fatigue, sir.
Yes, one can be because of the right-sided disease. There can be low cardiac output, which can result in less amount of oxygen flow into the exercising muscles or respiratory muscles, resulting in tired and fatigueness. Okay, right, 1, 2. There are many mechanisms by which in a patient with right-sided disease, there can be exertional breathlessness. Few of them, can you mention few of them?
Burning effect of the right ventricle on the left side.
You call it reverse Bernheim effect. Reverse Bernheim effect. Bernheim effect is actually bulging of the ventricular septum onto the RV, first described in aortic stenosis, where the RV function is interfered with because of the Bernheim effect. In a patient with severe pulmonary arterial hypertension and right side heart failure or right side involvement, sometimes there can be reverse Bernheim effect, resulting in encroachment into the LV function and that will result in exertional breathlessness. Yes, what else? Different mechanisms to explain exertional breathlessness in a patient who has got a right-sided disease. Any one of you? Another mechanism is the heart is a syncytium. Since heart being a syncytium, when the right ventricle is put to strain, there will be some effect on the left ventricle also. And intraventricular septal hypertrophy also forms a part of the LV cavity, and hence because of the syncytial effect, some malfunction can happen to the left ventricle also. Another reason is when there is an elevation of the right atrial pressure, there can be a consequential elevation of the coronary sinus pressure, because coronary sinus drains into right atrium, RA. And the coronary sinus is the venous drainage of the heart. So if the venous pressure goes up, what happens? Anyway, system is
It's a decrease in diastolic flow, which may be decrease in the coronary flows.
All right.
Increase in the pulmonary capillary perfusion pressure.
Yes, there will be increase in the pulmonary venous pressure and capillary pressure, resulting in
increased perfusion pressure.
not increased perfusion, that can result in myocardial edema.
Myocardial. Yeah.
See, whenever there is a increase in the venous pressure, there will be edema in that region. For example, if there is a systemic venous pressure elevation, that can result in edema of the lower limbs, edema, ascites, facial edema. All these things can happen. Similarly, when there is a increase in the coronary sinus pressure, that can result in myocardial edema. And when there is myocardial edema, that can reduce the compliance of the myocardium, resulting in LV and diastolic pressure elevation, and that will result in breathlessness. Okay, what else? Any other mechanism which can give rise to breathlessness in a patient with right-sided lesion? Any one of you? It may be because of the respiratory system involvement. For example, these patients can have sometimes pleural effusion. When they have got right-sided heart failure, they can develop pleural effusion. And pleural effusion can give rise to symptom of breathlessness. Either is many of these patients, the problem may be severe pulmonary arterial hypertension. When there is severe pulmonary arterial hypertension, what happens to the pulmonary arteries?
Pulmonary artery dilates.
Pulmonary artery dilates, they become big. And very often the left pulmonary artery, when it dilates, it can press upon
in one of the bronchus.
Left bronchus. It can press upon left bronchus, and that can result in sometimes even in a lung collapse, or there can be a difficulty in breathing, and that can result in symptom of breathlessness. Another mechanism explained is there are certain receptors in the lung which are known as J receptors, P receptors. They can also get stimulated, and that can result in sometimes a symptom of breathlessness. There are a number of mechanisms explained to explain the symptom of breathlessness in a patient with purely right heart disease. But the most important thing is that patients with right heart disease, even when they develop significant degree of breathlessness, they will not have. What is the symptom? What is the type of breathlessness? Orthopnea they can have.
PND.
They will not have.
PND will not be there.
So in a patient with right heart disease, PND will not be there. So when there is a PND, you must always think of the possibility of left-sided disease. Okay. Okay. What are the other conditions that we can think about a 29-year-old female? Rahul.
Yes, sir.
Sir, other differential diagnosis may be dilated cardiomyopathy.
Very good, excellent. Dilated cardiomyopathy also always must be thought of. And in the history, this lady has given birth to a baby a year ago. So we have to think whether this could be something like a peripartum cardiomyopathy or or even generally cardiomyopathy also must be thought of whenever somebody is coming, especially it may be post-myocarditis, and exertional breathlessness may be due to dilated cardiomyopathy like picture. Very good. Yes. What else?
Pericardial disease also can be kept in mind, sir.
Yeah, pericardial disease can be considered, especially exertional breathlessness, tiredness. There can be pericardial disease is a possibility, especially patients developing constrictive pericarditis in our part of the world, where the tuberculosis is much common. Sometimes patients can present with features of constrictive pericarditis. Yes. Anything else?
Restrictive cardiomyopathy.
Restrictive cardiomyopathy. Yes, right side restrictive cardiomyopathy or endomyocardial fibrosis can be thought of, but at this stage, yes, I agree with you. Endomyocardial fibrosis can be thought of, especially exertional breathlessness, tiredness, but that cannot explain the episode of giddiness on exertion. I think, but that can still be considered. Yes, do you think that this we have to consider aorta arthritis?
Yes, sir. It is a female
Yes, sir.
patients
Yeah,
that is more chances of non-specific aorta arthritis also possibility.
Yes, I think whenever in the examination, when you get a female around 25 to 30 or up to 40, below the age of 40, you should always consider a possibility of aorta arthritis.
Aorta arthritis.
Because if there is a patient of aorta arthritis, that will definitely be kept in the examination. So that also should be considered. So these are the few differential diagnoses that we will think about after hearing the initial complaints of the patient. So it could be patient with rheumatic heart disease or atrial septal defect who has started developing symptoms, or it could be primary pulmonary arterial hypertension, cardiomyopathy, or it could be different types of cardiomyopathy, dilated cardiomyopathy, or a restrictive cardiomyopathy, or it could be aorta arthritis because it is a young female. Okay, now let us go to the present illness. Any other differential diagnosis you would like to discuss and bring out from the symptoms? Any other differential diagnosis in your mind? I heard a female voice. Who is the female who is present? Okay. Any other differential diagnosis you would like to discuss from the symptom the patient has complained? Anybody? Okay, then we'll go to the story. Okay, Rahul, continue with the story.
Yes, sir. The symptoms started 3 months ago when she felt mild exertional breathlessness while carrying her 1-year-old daughter. The symptoms deteriorated quickly, and within 2 weeks, she started feeling breathlessness on normal routine activities. Class 2 symptoms. She had gained 10 kg of weight after her delivery and thought that the symptom is due to that. She consulted a local general practitioner who, after examination, told her that there is nothing serious and asked her to lose weight. Her symptoms quickly deteriorated and she started becoming breathlessness on minimal exertion for the past 1 month. Class 3 symptoms. She was comfortable at rest, no history of PND. She had one episode of giddiness on exertion 1 month ago, did not lose consciousness, no history of cough or hemoptysis, no history of palpitations or cardiac pain, no history of upper limb claudication. She consulted a cardiologist who said she has a heart disease and carried out investigations, including echocardiogram, and based on that, she was started on medication. She had minimal improvement. She was feeling tired even with mild exertion. For past 7 days, she had observed mild reduction in the urine output. Associated with this, she developed edema of both the legs. She is on 4 medications, one of which is a diuretic. And past history. She gave birth to her first child 1 year ago. No symptoms during pregnancy or after delivery. No history of rheumatic fever in childhood. No history of hypertension or diabetes. No history of congenital heart disease. Family history. Parents alive, both hypertensive. No diabetes. Siblings healthy. Habits. No habit. Restarted her normal menstrual cycles 4 months ago.
Okay. So now you discuss the story. From the story, whatever is available, do you like to have some more information, or are you happy with the information that is provided to you?
Yes, sir. During the delivery, any problem she was having?
Her delivery was perfect. She said she did not have any problems during pregnancy nor during delivery. It was a normal full-time delivery, and she had no complications. And till 3 months ago, she was carrying the baby, breastfeeding the baby. There was no problem.
So from story, it seems that the symptoms started and the symptoms progressed faster, sir. She initially she
Quickly
was
reduced.
asymptomatic.
She
Yes, sir,
quickly
she
deteriorated.
quickly deteriorated. So considering this and recent history of pregnancy, so we can think of possibility of myocardial disease, sir, which is progressing faster.
Like,
Probably dilated cardiomyopathy, like postpartum cardiomyopathy, sir.
okay. What is the time range during which patients present with peripartum cardiomyopathy?
Sir, 1 month before pregnancy and 5 months after the pregnancy, sir.
Not before pregnancy, 1 month before.
And 5 months after the
Delivery.
pregnancy.
Delivery.
Not 1 month before pregnancy. You have to be
1 month
careful.
before delivery.
Sir, after the 20 weeks of the gestations,
The third trimester and the first 5 months.
No. That is the if the patient who has got a heart disease, they can develop symptoms by about 28th week. But when you are thinking about peripartum cardiomyopathy, there is a definite definition, which is for a period of 6 months, 1 month before the delivery, and after up to 5 months after delivery. Of course, this is a provisional guideline, but patients can present with symptoms of peripartum cardiomyopathy even slightly later. It does not mean that at 5 months it suddenly stops. No, it can happen even around about 6 months. You must always consider a possibility of peripartum cardiomyopathy in any woman who comes with symptoms within a period of, let us say, 6 to 8 months after delivery. So I agree with you that peripartum cardiomyopathy should be considered. But what is the point against peripartum cardiomyopathy?
She presented a bit later, sir. She's having 1-year-old child.
Yes, she's
So-
presented about 9 months after delivery. That's odd. Yes, 1, 2.
And another thing is she's having giddiness. We are not able to explain. Maybe because of reduced ejection fraction, she's having giddiness.
Or it can be giddiness can still be explained. One may be reduced ejection fraction, or maybe patients with LV dysfunction. What can happen to them when they yes. Arrhythmias. They can develop arrhythmias. In patients with LV dysfunction, dilated cardiomyopathy, LV dysfunction, when they exert, they can develop arrhythmias, especially ventricular arrhythmias, and that can precipitate symptoms. So that can be explained. But is peripartum cardiomyopathy a left-sided disease or a right-sided disease?
It's a left-sided disease, but now the patient has edema of both lower limbs.
Yes. Mostly it's a mainly left-sided disease, and sometimes they can have some degree of right-sided disease also, but mostly it's a left-sided disease. But their symptoms are more referable to right-sided problem, and also there is no history of paroxysmal nocturnal dyspnea. So we will definitely keep peripartum cardiomyopathy as a possibility, but odd it is that she does not have symptoms of left-sided heart disease. Okay, yes. What else? Can this be primary pulmonary artery hypertension? We thought of the possibility of primary pulmonary artery hypertension.
So less likely because pregnancy was uneventful. So
yes,
progression so significant faster is less likely, sir.
So you feel that since during the pregnancy she was perfectly all right.
Yeah.
Yes, I agree with you that primary pulmonary arterial hypertension, if she had before she became pregnant or she was developing it, then she would have become very significantly symptomatic during pregnancy. What is the problem of primary pulmonary arterial hypertension in pregnancy?
Sir, in
Might worsen.
Individual significantly worse.
significantly worse.
It's associated with very high the fetal mortality and also significant maternal mortality. Maternal mortality is as high as 15 to 20%, and fetal mortality can be as high as 35 to 40%. There can be very high. What is the reason?
So in primary pulmonary hypertension, the right-sided output is fixed and there is increase in the volume overall. So the heart is not able to handle increased hemodynamic load. So RV patient has right-sided cardiac failure basically.
Okay. What happens is that in pregnancy, what are the hemodynamic changes of pregnancy?
There is hemodilution, the volume increase almost.
There's increase in the blood volume, yes.
There is increase in the heart rate, tachycardia.
The heart rate, yes.
There is increase in the cardiac output.
Increase in the cardiac output.
Peripheral vascular resistance is decreased.
Increase in the peripheral vascular resistance. So mostly three things increase and one thing decreases. That is the increase in the cardiac output, increase in the blood volume, increase in the heart rate, and decrease in the peripheral resistance. The patient with PAH, when the blood volume increases and the cardiac output increases, what happens to pulmonary artery pressure?
It decreases because pulmonary vascular resistance also decreases during the pregnancy.
No. The systemic resistance decreases. Pulmonary vascular resistance does not decrease. And when in a patient with pulmonary, in a normal person, pulmonary vascular resistance will not go up. But in a patient with primary pulmonary arterial hypertension, there can be a significant increase in the pulmonary pressure. As the cardiac output increases, there will be a significant increase in the pulmonary artery pressure, and that will result in significant. The patient can go in for right heart failure. So patients with primary pulmonary arterial hypertension significantly deteriorate during pregnancy. Okay, so if she was having primary pulmonary arterial hypertension at the time of pregnancy, she should have deteriorated, and she started developing symptoms only after about 8 to 9 months after her delivery. So, the lack of symptoms during pregnancy indicate that she must have been reasonably all right during that time. And if at all it is primary pulmonary arterial hypertension, then you have to think that the pulmonary arterial pressure started rising only after she has delivered. Yes. Okay. So we'll keep that slightly low in the list. We'll definitely consider peripartum cardiomyopathy. Anything else? Do you think that this can be ASD? We thought of the ASD.
ASD can be considered, but ASD will not deteriorate so fast, sir. We can expect like normal pregnancy course, but it should not deteriorate significantly faster. Only in case if patient develops some infective endocarditis, she may present with this, but she is not having any history of fever as such.
ASD is infective endocarditis common?
No, sir.
No, sir.
Usually, infective endocarditis is almost unheard of in a patient with ASD, because infective endocarditis usually happens when there is a fast jet.
Yes.
You need a fast, high velocity jet to produce the Venturi effect and infective endocarditis. In ASD, there is no fast jet. The flow across the atrial septal defect is very low, very slow speed, and velocity is very low. And these patients do not develop infective endocarditis. So infective endocarditis is not a complication of atrial septal.
ASD. Yes, sir.
So this patient after symptoms quickly deteriorated. That is a point very much against the possibility of
ASD.
ASD. Do you think that this could be some pulmonary embolism?
Can be considered, so chronic pulmonary embolism we can consider, but yes, we can keep that possibility in mind.
Yeah, but there is no direct evidence that there is no acute event and also
Yes.
there is no history of hemoptysis. So we don't have a direct clue that this could be a pulmonary embolism. Okay, right.
Yes.
So from the story, I think we have to consider that this could be a possibility in the order of preference.
Disease of myocardium, like peripartum cardiomyopathy.
Very good. Yes. Two.
Excuse me, sir.
Oh. Yes. Yes. You want to raise a point? Yes, please. You are not audible, or you unmute yourself and then raise the point. Hello. If you are not, yes.
Hello.
Yeah, yes. Hello. Am I audible to you?
Yes, sir.
So, but the person who wanted to raise a point, he is not audible. Can you unmute yourself and raise the point? Okay. In the order of preference, we will go for one peripartum cardiomyopathy. Do you think that we should consider ASD still?
We can consider, sir, but it should be lower in the list.
Lower in the list. What is the most important thing which actually causes sudden tilting of the symptoms in a patient with ASD?
Uncontrolled hypertension.
Yeah, no, but that is unrelated to ASD. Related to ASD, is there something which can actually cause a sudden deterioration of the symptoms?
Atrial fibrillation.
Atrial fibrillation. Atrial fibrillation can suddenly cause deterioration of symptoms in a patient with atrial septal defect. But from the story, you don't have any clue that she had any irregular palpitation, nothing to suspect that she had an arrhythmia. So we'll still keep that possibility, but slightly low in the list. Do you want to keep primary pulmonary arterial hypertension? You were suggesting that, Rahul?
Less likely, but sir, we will keep lower in the list.
We'll keep slightly lower in the list. Do you think that even though there is no history of rheumatic fever, should we consider a possibility of rheumatic heart disease also?
Yes, sir. No, sir. No, less likely because
less likely. It's very low even, unlikely. And so, if at all you want to keep diagnosed quite low in the list, do you think that this can be aorta arteritis?
Excuse me, sir.
No, sir.
Yes.
Sir, was there any history of fever, sir, in this case?
No history of fever. No history of fever.
Oh.
No, sir. It doesn't look like aorta arteritis because she's not having any other symptoms like malaise or fever or other things.
And also, see the most classical site of involvement of the vessel is the
subclavian arteries.
Subclavian artery. So subclavian vessel, immediately at the origin of the subclavian vessel, there can be significant stenosis of the subclavian vessel. Subclavian vessel involvement is a major criteria for the diagnosis of aorta arteritis. And she does not give any history of upper limb
ischemia or
claudication. So from the story, we don't have any clue to suspect aorta arteritis. Or when patients with aorta arteritis can present with systemic hypertension and they can have left heart symptoms. But there is nothing from the story where we can definitely draw a conclusion that this could be aorta arteritis. But since it being a 29-year-old female, I think we will, in our examination, we will look for any evidence of vascular involvement. Okay, any other point? Okay, we'll go to the physical findings. Rahul?
Can we consider RSO, sir, in this case?
Rupture sinus of Valsalva. So we usually, it's an acute symptom. Usually, very often happens when but that cannot explain the exertional graying. That cannot be explained. and ruptured sinus of valsalva usually will have a left-sided symptom because left heart
She's
is
not having any, no
overloaded.
chest pain also, so
No.
it looks less likely.
Less likely, but I think I'll keep very much low in the list because it's mostly a left-sided disease and an acute symptom, and very often they may have a chest complaint also. And all put together, possibility of ruptured sinus of valsalva, I would consider slightly low in the list. But as somebody has suggested, during the examination, we look for what is the most important physical finding of ruptured sinus of valsalva.
So thrill as well as murmur,
Yes.
continuous murmur.
Superficial thrill and a continuous murmur in which the diastolic component is louder than
Systolic.
systolic component. All other continuous murmurs you hear, systolic component is late systolic component is louder than the diastolic component. The murmur actually peaks towards the second heart sound and then it comes down. But in a patient with ruptured sinus of valsalva, the murmur will be louder during diastole, and you can actually feel a very superficial thrill in majority of these patients. Okay. Now we'll go to physical findings.
Can we consider Epstein's?
Exertional breathlessness, tiredness. Only thing is that they can have an arrhythmia, so we can
She's not having
consider
cyanosis also.
it's a right-sided disease. They can have tiredness, exertional breathlessness, and readiness cannot be explained. There is always a difficulty in explaining that. Epstein can be considered because sometimes Epstein patients can present with purely with the right side symptoms when they develop an arrhythmia. Usually they are prone to develop arrhythmias, atrial arrhythmias, and when there is an arrhythmia, they can deteriorate. But here there is no definite history of arrhythmia. But still, I agree with you that a sudden deterioration, there is a strong point against Epstein's anomaly because over a period of 2 to 3 months, she quickly deteriorated, significant deterioration. So that gives a possibility of either peripartum cardiomyopathy or a progressive pulmonary arterial hypertension higher in the list. Other things must be kept slightly lower in the list, including Epstein's anomaly. That can be thought of when we examine. We will carefully look for that also.
Okay.
Hello.
Yes.
Sir, patient without cyanosis, should we keep the possibility of Epstein's in the list, sir?
All patients with Epstein need not have cyanosis.
Okay.
What is the thing which decides cyanosis?
Sir, it is the flow.
Pulmonary flow, sir.
Not pulmonary flow. There should be a right to left shunt.
Right to left shunt, yes.
Yeah. How can there be a right to left shunt?
TR and from ASD it is going to the left side.
Yes, if there is a large ASD in a patient with patients who develop right heart failure, or patients in the early life when the RV compliance is very much reduced, and with significant tricuspid regurgitation directed towards the ASD defect. In these patients, there can be sometimes cyanosis. But many patients with Epstein will present without cyanosis. Cyanosis is not a definite accompaniment of Epstein's anomaly. If there is a cyanosis, it's very interesting that Epstein's anomaly patients can have cyanosis during early postnatal life. Then the cyanosis can disappear and it can reappear at later life. What is the hemodynamic basis of this behavior, Rahul? Epstein's anomaly patients initially can have cyanosis. It disappears, then reappears.
So during early childhood, the pulmonary vascular resistance is more. So patients are having more TR, which is having right to left shunt. As the pulmonary vascular resistance decreases, the right-sided outflow resistance is decreased. So the shunt from right to left is decreased. And again, when the patient goes into the right-sided failure, and again the right to left shunt increases in the later life. So.
Yes, two, three things happen. One, patients with initially after birth, as you rightly said, actually the cavity of the right ventricle is small. So because the cavity is small, the compliance of the right ventricle is reduced. That will result in the elevated RV and diastolic pressure, more tricuspid regurgitation during early part of life, and if there is a large ASD, there can be a right to left shunt resulting in cyanosis. Then gradually RV dilates, RV compliance improves, RV diastolic pressure falls, RA pressure falls, and that will result in less of left to right shunt, right to left shunt, and even there can be mostly left to right shunt that will result in disappearance of cyanosis. And as you rightly said, many of these patients over a period of time can develop RV failure that will result in elevated right atrial pressure. Again, the shunt becomes right to left and the patient can become cyanosed. So cyanosis can happen in a patient with Epstein's anomaly immediately after birth, can disappear and then it can reappear. But there are patients with Epstein's anomaly in whom there may not be cyanosis. And one more important thing which decides a cyanosis is the nature of the tricuspid valve. Many patients with Epstein's anomaly can have tricuspid stenosis also. They may have a valve displaced down, but there can be an obstructive tricuspid valve. Patients can have cyanosis early in life and may continue to have cyanosis. The cyanosis may not disappear at all. So in Epstein's anomaly, sometimes you may get patients who have got cyanosis continuously, and as the patient develops the right heart failure or RV failure, the cyanosis can become more and more, and the patients can readily deteriorate. So cyanosis in a patient with Epstein's anomaly can have various manifestations. One, there may not be any cyanosis. Two, cyanosis can appear during early postnatal life, and gradually it can come down, can totally disappear, and after about in the third or late third or fourth decade, the cyanosis can reappear. And in patients with associated tricuspid valve stenosis, there is some malfunction, maldevelopment of the tricuspid valve with, of course, the leaflet displacement is the characteristic feature of Epstein's anomaly. But patients with Epstein's anomaly can also have tricuspid stenosis, and when that happens, these patients may have cyanosis throughout their life, and the cyanosis may steadily deteriorate over a period of time. So the cyanosis in Epstein's anomaly can be quite varied, starting from no cyanosis to severe cyanosis throughout life. Okay, right. So Epstein's anomaly we'll keep low in the list because that will not explain an acute deterioration, especially in the absence of any symptom of arrhythmia. If the patient had a symptom of palpitation, irregular palpitation, then we could have thought that the development of atrial fibrillation has resulted in acute deterioration. But we'll still keep all these things in our mind when we do the examination, and then we'll come to the diagnosis. Yes. Physical findings. Okay. Rahul?
Yes, sir. On examination, a patient is mildly dyspneic, no cyanosis, clubbing or pallor, mild edema present around both the ankles, no dysmorphic features, no skeletal abnormalities, respiratory rate is 18 per minute.
What is the normal respiratory rate?
Normally, sir, 15 to 18, sir. 14 to 18.
No, 15 to 18 is too high.
16 to 24, sir.
No, not 24. What is the normal respiratory rate?
12 to 14.
It's 10 to 14. What is your name?
Sir, Adira.
Okay, Adra, okay. It is 10 to 14. Usually it is below 14. See, when you are in doubt, the best method is that usually respiratory rate is 1/5 the heart rate. So normally we consider the heart rate to be around 70, 72. So 1/5 of that is around 14. So usually the respiratory rate and the heart rate relationship will be around 1/5. So usually the heart rate is around 14, not 20. 20 is very high. 18, respiratory rate 18 also is slightly high. It's around 14. Okay, right? Yes?
Okay, sir. Then pulse rate is 90 per minute, regular, low volume, vessel wall not felt, all pulses felt normally. There is no radial or radiofemoral delay.
Now we can exclude.
So we can exclude the aorta arteritis
Yes. Possibility of aorta arteritis can be excluded. Yes.
Yes. So blood pressure is 110 by 90 millimeters of mercury in right upper limb. JVP, both A and V waves are prominent. A waves is 12 centimeter and V wave is 14 centimeter, and mean JVP is 10 centimeters elevated above the sternal angle, normal Y descent.
Whenever you are describing JVP is one examination which always students get stuck, and the patient and the examiner will go on asking questions, and there can be problems. So you should describe A waves, B waves, and mean pressure. It is very difficult for us to measure exactly what is the mean pressure. So what you can do is that mean pressure is usually 3 to 4 centimeters less than the height of the A or the B wave. So if the A wave is 12 and 14, very often the mean B wave pressure will be around 10 or 11, or maybe 9 or 10. So mean jugular venous pressure is around 3 to 4 centimeters less than the maximum height of the A or the B wave. So when you describe, you should always describe A wave, B wave, the mean JVP, and also if you can identify X and Y descent very well, that also should be described. Okay, yes. How will you identify A wave? How will you identify B wave? Rahul?
Yes. So A wave is because of atrial contraction. So
Yes.
that is during the diastole.
Yes.
So
it's a
that
pre-systolic event. It is a pre-systolic event just before
yes.
the systole. So yes. And
V wave is during the systole of the ventricle. So
yes.
it corresponds to the pulse actually.
Yes. So the V wave is a gradual filling of the right atrium during systole. So A waves precedes the carotid pulse, and V waves follows the carotid pulse. What is the wave which can occur at the time of the carotid pulse?
So C wave, sir.
C wave. C wave is the one which very often is difficult to observe. It is A and the B which are C. It is described that A wave is elevated 12 centimeters. What are the conditions in which A wave can be prominent?
So in right-sided failure, sir.
Not right-sided failure. Right-sided failure usually V wave is more prominent because these patients can have tricuspid regurgitation. What is the reason of A prominence?
Tricuspid stenosis.
Yeah, tricuspid stenosis is very good.
Pulmonary stenosis.
Yes?
Pulmonary stenosis.
Pulmonary stenosis. Any condition associated with pulmonary RV hypertrophy, like pulmonary stenosis, pulmonary arterial hypertension, where there is a RV hypertrophy resulting in reduced RV compliance, the A wave can be prominent. Yes? Tricuspid atresia.
Tricuspid atresia, yes.
Yes, sometimes
RSOV to RV.
Beg your pardon?
RSOV to RV.
No. RSOV to RV or not very often it can be RA. RA to RV. RV, why should the AV be prominent?
Because of the increased volume in the RV, sir, because the RV is receiving blood from both atria, RA, as well as from the aorta. So when the RA blood tries to go into the RV in the diastole, there is already enough blood in the RV, so there is an increase in the A wave.
Usually they will have a mean pressure elevation. That's what usually happens. The prominence of rather than the prominence of the A wave, it is actually there is a mean pressure because the RV diastolic pressure significantly goes up. That will result in elevation of the mean right atrial pressure. That's what usually happens. In a ruptured sinusal valsalva, A wave can be prominent. When you think of when you find an A wave prominent, the condition that you should suspect is that maybe the sinus is bulging into
right ventricular, right atrium.
No, to the tricuspid valve, tricuspid. The posterior, when the posterior sinus of valsalva, when it dilates and ruptures into right atrium, it may actually encroach onto the tricuspid valve and may cause something like a tricuspid stenosis, and that can result in a prominent A wave. Otherwise, it is actually the mean pressure which significantly gets elevated. Yes, okay. How will you recognize Y descent and X descent? How will you recognize X descent and Y descent? Anyone of
Again,
you?
X descent is a atrial during atrial relaxation phase. So it is like during the ventricular systolic phase. So that is systolic event, and V wave is sorry, Y descent is because of filling of the ventricles. So it is a diastolic event. So accordingly, we can corresponds with the pulse, which is uh, uh, before the pulse is Y, and after the pulse is X descent. So.
Before the pulse is Y. What do you mean by that?
So it is diastolic event. So during pulse, it will not occur during this pulse. So which is not corresponding with the pulse is a Y wave, Y descent, and which is
best method for you to make out which is X descent and Y descent is to auscultate.
Correlate with second heart sound.
Second heart, very good.
Sir, if you
the one which
can identify A and B waves, you can time accordingly, sir.
Beg your pardon? Yes.
If we can identify A and B waves, we can time accordingly.
Yes, that also is possible.
After A comes X and after B comes Y.
Yes, that also is possible. But sometimes if these waves are not very prominent, if you want to make out which is a X descent and Y descent, you can auscultate. And the one which the descent which occurs with the second heart sound is the Y descent.
Y descent.
The other one is the X descent. So you can auscultate the pulmonary area and simultaneously observe the jugular vein pressure column. If the X descent, if the one which corresponds to the second heart sound, the descent is the Y descent. Then once you recognize the Y descent, you can, the other one can be the X descent. So if you are asked a question, how will you identify Y descent? The answer is that you auscultate, and the descent which corresponds to the second heart sound is the Y descent.
Y descent.
Well, what does the normal Y descent tell you?
There is
Absence
no
of
tricuspid stenosis.
Yes, there is no tricuspid valve obstruction, and also pelvis is able to receive blood without much problem. So the normal Y descent is indicates that there is no tricuspid valve obstruction. Okay, very good. Yes. Then precordial examination.
In precordial examination on inspection and palpation, apex beat is seen and felt in the fifth left intercostal space, 1 centimeter outside the midclavicular line. It is forceful when traced medially. The apical impulse is continuous with the parasternal impulse.
What does that mean?
So it is formed by the right ventricle. Sir.
Yes, the apex is formed by the right ventricle. Very good.
There is no thrill or sounds palpable at the apex. The parasternal heave present, grade 3/3.
What do you mean by grade 3/3?
Sir, it is not obliterable, palpable and not obliterable.
Is easily felt and cannot be obliterated by reasonable pressure. It is not that you should apply a very heavy pressure, but with certain reasonable pressure, it cannot be obliterated. Yes, very good. Yes. What does that usually indicate when there is a difficulty in obliteration of the parasternal heave? What does that indicate?
Sir, there is a pressure overload.
Pressure overload. Usually it indicates pressure overload. Very good. Yes. Okay, go ahead.
There is no thrill or sounds palpable in parasternal region. The S2 palpable in the pulmonary area. No thrill. Pulsations are felt in the pulmonary artery. Right ventricle pulsations are felt in the epigastrium.
Yes. So from this, what do you think? What are the possibilities in your mind? It's mostly a
right-sided pressure overload.
Right-sided pressure overload. Okay,
Pressure overload.
Okay, the right-sided pressure overload, and 1/2 sound is palpable. So you have got every reason to believe that there could be pulmonary arterial
hypertension.
Hypertension. Okay, yes. Okay, go ahead. Percussion.
So on percussion, there is a left border at the level of the apex corresponds to the apex beat. Second left intercostal space close to the sternum has impaired percussion notes up to 3 centimeter from the sternal border. and the second right intercostal space is resonant. The right heart border dullness extends 2 centimeter beyond the right sternal border, sir.
What does that mean?
So that means there is a enlargement of the right atrium also as well as right ventricle.
There is some degree of enlargement of the right atrium. That is the reason why the right border is extending beyond the right sternal border. Okay, very good, excellent. Auscultation, you are doing very well. Rahul,
Yes.
very good, excellent. Yes.
Yes. Sir, on auscultation, S1 is audible.
Rahul, where from which center are you? From which center?
Sir, I am from Pune, sir, Jahangir Hospital, sir.
Jahangir Hospital. I think you're good. I think you are getting properly trained. Very good, excellent. Yes, auscultation.
Yes, sir. On auscultation, S1 is audible all over the precordium, best audible at the mitral area, normal in intensity. S2 is audible all over the precordium, best audible at the pulmonary artery.
Pulmonary area.
Pulmonary area, sorry.
Okay.
It is loud, normal split. RV-S3 audible at the tricuspid area. There is a constant ejection click in the pulmonary area. Blowing pansystolic murmur, best audible in the lower sternal border and heard up to the apex. Increase on inspiration and passive leg rising. There is no radiation. Grade 3/6. There is early diastolic blowing high-pitched murmur in the pulmonary area and heard down along the left sternal border. Duration more than half the diastole. Increases with the second or third within second third beats of passive leg rising. There is no change with the breathing. Starts with P2, grade 2/6.
Okay, now you discuss the physical findings.
Yes, sir. So the patient is having ejection click as well as there is a pansystolic murmur as well as diastolic murmur. So it looks like patient is having both pulmonary stenosis as well as regurgitation, sir.
Why did you say pulmonary stenosis?
Sorry, sir. More likely the ejection murmur is because of can be because of flow increased volume or.
Where is the ejection murmur?
It's a TR murmur.
TR murmur and PR murmur.
Yes, sir. TR murmur and PR murmur. Sorry, sir.
Patient is having a blowing pansystolic murmur.
Pansystolic.
Now, before that, you take the sounds. S1 is normal. What is happening to S2?
S2 is audible all over the precordium, sir.
Yes, it is it's loud.
Loud.
What does that mean?
Pulmonary
that means he is having pulmonary hypertension, sir.
What is when the patient is having pulmonary arterial hypertension, what happens to splitting of the second heart sound?
Narrows down.
Narrows down. What is the reason?
Sir, because the ejection right-sided ejection time is increased, so
pulmonary hangout interval.
Pulmonary hangout interval decrease. Yes.
Yes, there is a decrease in the pulmonary hangout interval. So the P2 come closer to A2, and it becomes a close split of the second heart sound. What do you mean by close split?
A2 and P2 are close together, sir.
Which can neither be heard in inspiration or expiration.
Actually, when you use the word close split, you are actually saying that the A2 P2 interval is around 20 milliseconds. Normally, A2 P2 interval, unless it is 30 milliseconds, you will not be able to appreciate. But in a situation where the second component is very loud, this can happen in a patient with pulmonary arterial hypertension. It is observed that even a difference of 20 milliseconds can be appreciated as two separate sounds. So, in a patient with pulmonary arterial hypertension, one, there is a reduced compliance, so reduced hangout interval, making P2 closer to A2. Two, because of the P2 being very, very loud, even with 20 milliseconds of interval, the P2 can be heard as a separate sound, and that will result in close splitting of the second heart sound. But here it is written that it is normally split. What is your explanation?
RV dysfunction might have set in.
Very good, excellent. Who said that? Who said that? What is your name?
So Sagar.
Very good. The patient might have developed RV dysfunction. When the patient develops RV dysfunction, what happens to P2?
It becomes widely split. There is a wide split.
P2 moves out, resulting in wider splitting of the second heart sound. And when there is something which decreases the second heart sound, decreases the gap between A2 and P2, there's another thing which increases the gap between A2 and P2. Ultimately, that can result in a normal splitting of the second heart sound. Very good. So, in a patient with loud P2, where you think suspecting significant pulmonary arterial hypertension, if you are getting a normal split, you should always suspect that patient may be having RV dysfunction.
RV dysfunction. Yes.
Very good. Yes. Okay. Right. RVS3 audible. How will you identify whether it is RVS3 or not?
Sir, RVS3 will be heard more in the tricuspid areas. Huh?
Okay. It will be audible in the tricuspid area. 1, 2.
And with inspiration, it will be prominently
very good. It will become louder during inspiration as well as in passive leg raising.
Yes.
You do a passive leg raising or ask the patient to breathe in, the sound can become louder. So that will help you to make out whether there is a third heart sound or not. Okay, very good. Yes. Then there is a constant ejection click. What does that mean? Where is it coming from?
pH can be vascular click, sir.
Yeah. Which vascular click?
Pulmonary artery, because of dilated pulmonary arteries due to secondary pulmonary hypertension.
Okay. So in patients with pulmonary arterial hypertension, there can be vascular click. What is the mechanism of vascular click?
Sir, it is because of reverberation of the sound created by the pulmonary valve.
Yes. When the pulmonary valve opens, there is always a very small noise is produced. But normally it is not audible because it does not reverberate. But in a patient with a dilated pulmonary artery, small noise can reverberate and that can result in a vascular click, which is a vascular ejection click. In patients with what situation you can get inconstant or variable ejection click?
Sir, in pulmonary stenosis,
patients with pulmonary stenosis, you can have sometimes inconstant or a phasic ejection click. What is the mechanism?
Sir, during inspiration, the flow from the right ventricle to the pulmonary arteries increase. So there is a doming of the pulmonary valve, and when there is a lesser flow during the expiration, it is relatively less.
No, that's not correct. Your explanation is not correct. During inspiration, what happens?
Sir, increased flow during inspiration, more venous return is increased.
But there is an increase in the venous return to right atrium, and consequently more blood will flow to the
right ventricle and pulmonary artery.
Right ventricle. No, don't hurry. More blood will go flow to the right ventricle. In a patient with pulmonary stenosis, what will happen to the right ventricle? What is the thickness of the right ventricular myocardium?
It will be increased, sir.
It will be increased. So it will be, RV becomes less compliant, and into a less compliant RV, more volume of blood comes. What will happen to the diastolic pressure in the RV?
It will increase, sir.
It will increase. And when the diastolic pressure in the RV increases, and if it goes beyond that of the pulmonary artery pressure, what will happen to the pulmonary valve?
Early opening will happen.
It will dome out, and it may even open because of the diastolic pressure in the RV. When there is during inspiration, may exceed the diastolic pressure in the pulmonary artery in a patient with severe pulmonary stenosis, resulting in opening of the tricuspid valve and absence of the click. While on the other hand, during expiration, when there is less amount of blood is coming to the right side, the RV pressure may not exceed the pulmonary diastolic pressure, and hence still there can be doming and the click is audible. So the click in the valvular click of pulmonary stenosis can be phasic, audible during expiration and not audible during inspiration. The reason is that during inspiration, when a large volume of blood coming to the right atrium and consequently to the right ventricular diastolic pressure can go up, especially the end diastolic pressure, which may even exceed the pulmonary artery diastolic pressure, resulting in doming and even opening of the pulmonary valve towards the late systole, towards late diastole, and hence the ejection click may be absent. Is it clear to you?
Yes, yes.
Yeah, okay. So then two murmurs.
Sorry, sir.
There are two murmurs described. You interpret the murmurs. There is a
yes,
blowing.
One is tricuspid regurgitation murmur.
Why did you say this tricuspid regurgitation?
Because it is pansystolic murmur, sir.
Yes, very good.
And it is associated with the RVS3 also.
Yes, and also there is a increase on
inspiration.
Inspiration and passive leg raising. So
passive leg raising,
to suggest that it is a tricuspid regurgitation murmur. Okay, next, what is the second murmur?
Second murmur is pulmonary regurgitation murmur, sir.
Yes, there is a pulmonary regurgitation murmur. What happens to pulmonary regurgitation murmur during inspiration?
So during inspiration, the murmur should decrease because there is already increase in the pressure in the RV. So murmur should decrease because there is a less flow from the pulmonary artery to the right ventricle.
It's not the reason. I agree with you that usually the right side events usually increase on inspiration, but pulmonary regurgitation may not increase on inspiration.
Yes, sir.
It can increase sometimes, but may not increase. What is the reason?
Because RV end diastolic pressure is increased.
It has nothing to do with the end diastolic pressure. What happens during inspiration? What happens to pulmonary artery diastolic pressure?
So during inspiration, there is increase in the pulmonary compliance, so the diastolic pressure should decrease.
During inspiration, the lungs expand, the capillaries open out, and that will result in sometimes even better the vascular bed increases, and that can result in
decrease in the
pulmonary artery diastolic pressure. If pulmonary artery diastolic pressure slightly decreases, what will happen to pulmonary regurgitation? Pulmonary regurgitation can come down because of the gradient comes down. But then during inspiration, there is a larger volume of blood coming from the right ventricle, and hence the pulmonary regurgitation murmur usually does not change much during inspiration. There's a compensation because of the lower pulmonary artery pressure, and also an increase in the pulmonary the RV ejection can result in practically no change in the pulmonary regurgitation. So, do you think this is a pulmonary regurgitation or aortic regurgitation?
So pulmonary regurgitation, sir.
Why?
So because it is patient is already having pulmonary hypertension as well as tricuspid regurgitation.
Very good.
So that because of pulmonary hypertension, she is having.
Whenever you are asked a question about aortic regurgitation, pulmonary regurgitation, you must always look at the blood pressure.
Yes, sir.
And the patient is having a low volume pulse and blood pressure of 110 by 90 millimeters of mercury. That is a very unlikely the blood pressure in the patient with any significant degree of aortic regurgitation. And also the LV is the apex is formed by the RV, and hence all features are towards the RV involvement other than LV involvement. Okay, so
yes,
from all these findings, what do you think is the why you have to put your provisional diagnosis?
Provisional
diagnosis.
Yes.
Sir, it's also written that it starts with P2, so it's more likely to be a pulmonary regurgitation murmur.
Very good.
If it starts with A2, then it will be more likely to be a AR murmur.
Yeah, very good. The sense that the auscultation, it is made out that the murmur is starting with P2. That is an additional point for us to say that it is a pulmonary regurgitation. Okay, right. Yes. So, what are the possibilities that you are thinking?
So possibilities are like pulmonary, primary pulmonary hypertension, which is giving rise to pulmonary regurgitation and tricuspid regurgitation.
Yes, I think we have to think of the possibility of primary pulmonary. Do you think there is a peripartum cardiomyopathy?
Less likely because it should not give pulmonary hypertension within short span of time.
Which ventricle is mostly affected in peripartum cardiomyopathy?
Left sided, sir. Left sided.
Is left ventricle. It's the left ventricle which is affected. Here, everything is suggestive of RV involvement, and hence the possibility of peripartum cardiomyopathy is extremely low. Do you think that could be AST?
No, sir.
No, why?
Because right-sided system is more commonly involved, and there is no ejection systolic murmur or on the aortic area.
Yeah, in the pulmonary. The ejection systolic murmur is not there. That's a point. But AST can still be considered because, see, of course, she has developed some degree of pulmonary arterial hypertension. But AST we will have to rule out by from the investigations. I think I'll keep my mind open, but I will definitely agree with you that primary pulmonary arterial hypertension would be the first possibility. Okay, shall we go for the investigations? What
Considering ASD patient with so much of an pulmonary hypertension would likely have some amount of cyanosis.
There is a possibility. I agree with you that cyanosis need not be there. There can be sometimes mild degree of or the shunt may be becoming less and less. I agree with you that the pulmonary arterial hypertension of this grade, we expect the patient to have some degree of cyanosis. So we'll keep slightly low in the list in order to keep our mind open. Because when we look at the investigations like X-ray and ECG, let us keep our mind open so that at the end of the X-ray and ECG, we can come at the correct diagnosis.
Okay.
Okay, right now we'll go to what would you like to see, X-ray or ECG?
Sir, X-ray, sir.
X-ray, you would like to see X-ray. Why do you want to see X-ray first?
To see for the right-sided system as well as vascular blood flow.
Yeah, see, if you are thinking of a possibility of a atrial defect, the X-ray is much more important than ECG.
ECG. Yeah.
Okay, yeah, very good. Your point is correct. But anyhow, I'll show ECG first. Okay, what do you interpret the ECG?
So this is normal standardization. There is sinus rhythm. The rate is around.
That's not matter. A normal rate. Okay, right.
Normal rate, yes.
Don't waste time on rate and all too much. Whether it is reasonably or normal, you say normal rate. Okay,
yes, it is normal rate, and there is.
What is the axis?
Sir, axis is
right axis deviation.
Right axis deviation around 110. Around 110. Yes, so there's right axis deviation. Yes. What else? Is there evidence of RVH?
RVH is there. Yes,
RVH, significant RVH. Do you think that from looking at the pattern, do you think that is the RV pressure suprasystemic? What is the ECG evidence in which you may suspect that the RV pressure can be suprasystemic?
Sir, RV more than 11 millimeters, and there should be a strain pattern.
Yes. When there is a QR pattern with strain, that's very good. When there is a QR pattern in B1 with a strain, that's most likely it is a suprasystemic pulmonary artery. And also the strain pattern is extending up to B4. So every possibility that this patient may be having suprasystemic
pulmonary hypertension.
Look at the ECG X-ray. Okay, X-ray chest. Okay.
So this X-ray chest, PA view, normal exposure.
Okay.
Slightly rotated film, sir.
Slightly rotated, very good. Yes.
Sir, there is cardiomegaly. CT ratio is
on visual observation. There is a visual assessment. There is mild cardiomegaly. Very good. Yes.
Yes, sir. There is a prominent pulmonary artery.
Yes, pulmonary artery is prominent.
Yes, there is apex looks like RV type. There is slight upward
I may not
Or should we
comment.
comment? Yeah, yes.
I may find it difficult to comment, but I may say that definitely it is not, from the X-ray wise, it is more likely to be RV than LV. But I will not comment that it is only RV apex. I will say that apex seems more like RV than LV. Okay, right? Yes.
RA.
Is there an RA enlargement?
Doesn't look like much.
Yes, there's no evidence of RA enlargement because RA enlargement we will diagnose by looking at what are the points for you to diagnose RA enlargement.
So the RA border should be at least covering 3 intercostal spaces, more than 2.5 intercostal spaces.
Very good. Yes, the vertically RA should be extending more than 2.5 intercostal spaces. Yes.
Yes, or it should extend at least 5 centimeter from the from the center of the X-ray.
5 centimeters and all typical only when you are looking at a standard X-ray which is taken at 5 feet distance. But what you should look at is that the right border of the heart extending beyond
Beyond
medial one third of the right hemithorax.
Right. Yes.
So looking at the X-ray, there is no evidence for us to suspect that there is. Of course, this is a slightly rotated film, so you can't be 100% certain. But I would consider, I will not comment about the right atrial enlargement because it is a rotated film, so our assessment about the right atrium may be slightly wrong. But most important thing we are looking about is pulmonary vascularity.
Vascularity, yes, sir.
What do you think about the pulmonary?
Looks reduced, sir.
It is a normal, or I won't consider that it is a, there is no plethora. So that immediately rules out the possibility of
ASD.
ASD is unlikely because we are not finding it, because ASD is one condition where there can be significant plethora and we are not able to diagnose plethora. How do you diagnose plethora from the X-ray chest?
There are increased vascularity or apical vessels are prominent, as well as the vessels are extending up to the lateral 1/3 of the.
One is the more and more vessels will reach the lateral 1/3 of the lung field. 1, 2.
Prominence of the
endon vessels.
Endon vessels. You will be able to see endon vessels. What is the criteria?
More than 3
on one side or more than 5 on both the sides.
Yes, more than 3 on one side or more than 5 on both sides put together. So we are not seeing any endon vessels, nothing. So there is nothing for us to suspect the patient is having
ASD.
Shunt. There is no evidence to suspicion. Okay. And do you like to see the electroechocardiogram? Yes.
Yes.
Yes. What do you think?
So this is left upper one is parasternal long axis view.
All are parasternal long axis view. All are long parasternal long axis view. Okay.
Yes.
What all things can you make out?
So left atrium, it looks normal, sir. The aorta is also normal.
Okay.
It is mild left ventricular thickness is there.
RV is
enlarged. What is the portion of the here? What you are seeing is which portion of the RV? Is it RV or RVOT? Yes, very good.
RVOT.
So what you are seeing here is the RVOT. So the RVOT is dilated. What is happening in the endoventricular septum?
It is bulging towards the left side, sir.
No, is it moving with RV or moving with LV?
It is moving with RV, sir.
Yeah, it's moving with RV. See, when the mitral valve is closed, it is moving towards RV. See, if you are very careful, you can make out that the mitral valve is closed, it is moving towards RV, indicating that the endoventricular septum is moving with RV. That is a feature of
right-sided pressure overload.
Yeah, right-sided volume overload as well as pressure in both. It can happen more often in volume overload than in pressure overload. It can happen in both conditions. So volume as well as pressure. Then is there any aortic regurgitation or mitral regurgitation?
No, sir.
No,
nothing significant, sir.
No, there is no significant aortic regurgitation or mitral regurgitation. Okay. Okay. Now what do you think here?
D-shaped LV cavity.
Okay, very good. What do you mean by the D-shaped LV cavity?
Dilated right ventricle.
Yes.
Flattened interventricular septum.
Yes, flattened interventricular septum. What does that indicate?
RV
Systemic
enlargement.
pressures.
Yeah,
Suprasystemic RV pressure.
when that's flattened interventricular septum, that usually
Pulmonary
indicates
pressure is more than systemic pressure.
Yes, the RV pressure is more than the systemic pressure. And you can very easily make out that there is when the mitral valve is open, it is moving towards the LV. When the mitral valve is closed, it is moving towards the RV, indicating paradoxical septal movement, which is further confirmed here. Can you easily make out here? Can you make out here?
Yes, sir.
Yeah, there is a and what about the LV function here? Ejection fraction is 61% normal. Okay, right. Now we'll go to the next one. We have to look at the AST. Can you see just? Okay, what is this? What does it indicate?
PR, sir. Pulmonary regurgitation.
Pulmonary regurgitation. So our clinical observation that there was a early diastolic murmur and pulmonary regurgitation is correct. Okay, right? Yes. What is this?
Pulmonary velocity is normal.
Pulmonary velocity is it normal?
No, sir, it is increased.
No, sir, it is increased.
The ejection velocity is normal. I agree with you.
Ejection
Not increased.
40.
But actually slightly increased 1.42. What may be the reason why there is a increase in the pulmonary velocity? Normal pulmonary velocity is less than 1 meter per second, usually about 0.7. Here it is 1.42. What is the reason?
Increase in the RV pressure. Increased RV pressure would lead to increased.
Increased RV pressure will not give rise to
increase RV. Right, because of pulmonary regurgitation, increased volume.
Very good, very good. When there is a pulmonary regurgitation, there is increased volume, and that can result in increase in the stroke volume. So that can give rise to slightly higher pulmonary valve velocity. That is why 1.42 is high. What are the pressures that you can make out? What is this tracing? Is it what is this tracing?
PR jet.
PR tracing.
Regurgitation.
And from PR you can take out 2 points. One, the early diastolic gradient and the late diastolic gradient. What do these things indicate? From the early diastolic gradient, what is the pressure that we can make out?
The right-sided RV pressure.
Right-sided RV pressure.
Mean PA pressure.
Mean PA pressure. So whenever you are looking at the early pressure in a pulmonary regurgitation, that will give you an idea about the mean pulmonary pressure.
Mean pulmonary.
And a late pressure gradient will give you an idea about the
diastolic pressure.
Diastolic pressure. Okay, so here actually both, and to get these values, you have to look at the gradient, and to that you have to add the right atrial pressure. So we'll have to get an idea about the right atrial pressure. We'll look at that also. Okay. Okay, what does this indicate?
There is significant tricuspid regurgitation.
Yeah, there is significant tricuspid regurgitation. And what is happening to intra-atrial septum?
Bulging towards left atrium.
But it is bulging towards the left atrium. RV is dilated. Okay, RV is dilated. And what is the PR velocity?
5 meter per second.
5. So obviously the maximum pressure gradient is the pressure gradient between R and RV is around 101. Yes, and on top of that, we have to add the right atrial pressure. We look at the right atrial pressure also, because we have found the systemic pressure is 110. We would like to know whether it is a suprasystemic RV pressure.
Yes.
Okay, what do you think is the right atrial pressure?
It should be more than 15, sir.
At least 15.
What is the criteria?
It is dilated, and actually we should look for the IVC also. If it is more than 21 millimeters and it is less than 20% collapsible, then it is more than 15.
No, you have got you have all these things are here, so you can see the inferior vena cava. Here is the tracing. How will you assess the pressure in the right atrium?
If it's dilated and non-collapsible, the pressure is at least 15 mm of Hg, RA pressure. If it is dilated but more than 50% collapsible, the pressure is around 8 to 10.
More than 50% collapsible.
Dilated and more than 50% collapsible.
Yeah, what do you mean by more than 50% collapse?
With respiration, sir.
No, wrong.
Sir, with the deep inspiration, more than 50%, with the around 30% with the normal inspiration.
That also is wrong. You are partly right. During sniffing, there is a forced inspiration, more than 50% collapse, and normal breathing, 20% collapse. With normal breathing, collapse should be around 20%, and with sniffing, the forced inspiration, it should be 50%. And here, you can see that the size is 2.22 centimeters, and during inspiration, the collapse is very little, maybe less than 10%. So most likely, the right atrial pressure in this patient is
more than 15.
More than 15, and that is quite consistent with what we found in the jugular venous pressure column. It was grossly elevated. And what does this indicate?
Sir, RVH.
TAPSE. Here the TAPSE is 1.1 centimeter. What does that indicate?
RV dysfunction.
RV dysfunction. So there is a significant RV dysfunction. Very good. Okay, this is the left-sided this mitral valve flow. This is the aortic valve flow. Anything abnormal?
No, sir.
No, it's normal. Okay. Do you think that this patient may be having an ASD? Do you think that the patient may be having an ASD? If the patient is having a large ASD, which can result in pulmonary arterial hypertension and all, what will happen to the endothelial septum?
It will be normal. It will not bulge towards
it cannot bulge into the left atrium, LA. Because in a patient with large ASD, the pressure in the right atrium and left atrium will be
decompressed.
Same. The same.
Pressure equalization.
Pressure equalization of the right atrium and the left atrium, and hence the endothelial septum will be in the central point. So the bulging of the endothelial septum onto the left atrium strongly says that there is unlikely to have any ASD. A large ASD. There can be minor, small ASD we cannot rule out, but unlikely to have any ASD of any significance. Okay, right? Yes. So what is our final diagnosis?
So final diagnosis is pulmonary hypertension, severe pulmonary hypertension,
suprasystemic, yes.
Yeah, with severe pulmonary
severe mitral tricuspid regurgitation, severe pulmonary
regurgitation,
RV dysfunction,
yes,
RV failure.
Yes, RV failure, most likely because of primary pulmonary hypertension. Without patient is in sinus rhythm, there is no other signs of infective endocarditis or rheumatic heart disease.
Okay, and a few points about pulmonary arterial hypertension. When you diagnose, when will you say that the patient is having pulmonary arterial hypertension according to the definition?
It is a diagnosis of exclusion, so other things.
No, that is primary pulmonary arterial hypertension. I am asking pulmonary hypertension. When will you say
pulmonary arterial pressure is more than 25?
Right, okay. The main pulmonary artery pressure should be equal to or more than 25 millimeters of mercury.
25 millimeters.
Yes. Pulmonary hypertension can be classified into pre-capillary and post-capillary, or it can be sometimes even combined. What is the difference between pre-capillary and post-capillary?
Wedge pressure, pulmonary capillary wedge
Post-capillary.
pressure.
Yes, these are the points which will help you. The pre-capillary pulmonary hypertension. Okay, the pre-capillary pulmonary artery hypertension. Of course, the main pulmonary artery pressure should be equal to or more than 25 millimeters of mercury. Pulmonary artery wedge pressure should be less than 15 millimeters. That is the most important point which differentiates pre-capillary from post-capillary. So pulmonary capillary wedge, or it's more correct to use the word pulmonary artery wedge pressure, should be equal to or rather less than 15 millimeters of mercury. Cardiac output can be normal or reduced, and the pulmonary vascular resistance should be. What should be the pulmonary vascular resistance when you think that patient has got pulmonary arterial hypertension? Roughly, pre-capillary pulmonary arterial hypertension.
More than 3 Wood's
More than
units.
3, very good. It should be more than 3 Wood units. It should be more than 3 Wood units. Very good, yes. And the various pulmonary hypertension comes under this category of pulmonary arterial hypertension. In this one, most important one is idiopathic pulmonary hypertension and Eisenmenger syndrome.
Due to lung disease.
Eisenmenger syndrome. Then group 3, pulmonary hypertension due to lung disease. Group 4, chronic thromboembolic pulmonary hypertension. Group 5, pulmonary hypertension with unclear or multifactorial mechanism. All these are pre-capillary pulmonary artery hypertension. 1, 3, 4, 5. And the number 2, the group 2 one is the one pulmonary hypertension due to left-sided heart disease. And the most important differentiating feature is
capillary wedge pressure.
Capillary wedge pressure will be more than 15 millimeters of mercury. How will you make out the patient is having only passive elevation of pulmonary artery pressure, or whether there is some degree of reactive of pulmonary artery pressure? This can be made out by 2 measurements. One, trans-pulmonary gradient, that is mean pulmonary artery pressure minus pulmonary artery wedge pressure. If it is more than 12, indicates there is reactive pulmonary artery hypertension. If it is less than 12, it indicates passive pulmonary artery hypertension. But if you apply mean, the pulmonary artery diastolic pressure minus pulmonary capillary wedge pressure or pulmonary arterial wedge pressure, if it should be less than 5, it is definitely normal. Up to 7 also can be taken as normal. But if it is more than 7, then that indicates there is evidence of pulmonary reaction. So the passive elevation, when the pulmonary, the transpulmonary gradient is less than 12, or pulmonary diastolic pressure minus pulmonary arterial wedge pressure is less than 5 or less than 7, that indicates there is only passive pulmonary arterial pressure in a patient with post-capillary pulmonary hypertension. Now coming to pathology, what is the pathology of pulmonary hypertension? We can consider, I have made it very simple for you to absorb. The pulmonary pathology mostly involves the vessels, pulmonary vessels of less than 500 micrometers or mu in diameter. It is not the large vessels which are affected, but the small vessels are the one which are affected. The grade 1 change is a medial hypertrophy. You will find the media of the vessel hypertrophies. Grade 2, intimal proliferation and fibrotic changes. The intima proliferates and there will be fibrotic changes in the media. Grade 3, adventitial thickening with moderate perivascular inflammatory infiltrates. And grade 4, complex lesions like plexiform or dilated lesions, ruptured vessels, and thrombotic lesions. Grade 4 changes occur only in patients with Eisenmenger syndrome or patients with primary pulmonary arterial hypertension. In patients with pulmonary hypertension due to a left heart disease, usually it goes only up to grade 4. Very rarely, or rather, grade 4 changes do not happen. Only up to grade 3 changes occur. Grade 4 changes are complex lesions. It may be plexiform malformations, dilated vessels, ruptured vessels, and thrombotic lesions. This gives rise to hemostasis and a significant increase in the pulmonary arterial hypertension. You should be very clear about the pathology. Examiners may ask you about the pathology of pulmonary hypertension. The simplest way to look at it: grade 1, medial hypertrophy; grade 2, intimal proliferation of fibrotic changes; grade 3, adventitial thickening and moderate perivascular inflammatory infiltrates; grade 4, complex lesions like plexiform, dilated lesions, ruptured vessels, and thrombotic lesions. And grade 4 lesions are usually seen only in patients with primary pulmonary arterial hypertension or in patients with Eisenmenger syndrome. The classification of the pulmonary hypertension classification, the group 1 is pulmonary arterial hypertension, which includes idiopathic, heritable, drug or toxin-induced or associated with congenital heart disease like Eisenmenger syndrome or those associated with connective tissue disorders. Pulmonary veno-occlusive disease leading to pulmonary arterial hypertension also is included in this category. Sometimes newborns may have persistent pulmonary arterial hypertension and they come under the same category. Group 2, pulmonary hypertension due to left heart disease. Group 3, pulmonary hypertension due to lung disease, COPD. Group 4, patients with chronic thromboembolic pulmonary hypertension. And group 5, patients due to unclear or multifactorial cause. So this is a very simple, I have made it very simple for you to quickly grasp it. Group 1, pulmonary hypertension, which includes all these. Group 2, pulmonary hypertension due to left heart disease. Group 3, pulmonary hypertension due to lung disease, COPD. Group 4, chronic thromboembolic pulmonary hypertension. And grade 5, pulmonary hypertension due to unclear or multifactorial causes. Okay, now coming to the treatment. Anybody would like to discuss treatment? Rahul, you can read treatment.
Yes, sir. First is calcium channel blockers with reactive pulmonary hypertension.
Yes. How do you diagnose vasoreactive pulmonary hypertension?
Sir, right pulmonary, basically pulmonary catheterization should be done. Yes. And with the pulmonary vasodilators like nitric oxide, yes, is given, and we should see for the drop in
oxygen also
100% oxygen. Yes.
Okay.
And we should see for the drop in the pulmonary pressures. It should drop at least 20 millimeters of mercury, or it should fall below 40 millimeters of mercury.
Yes, it should be vasoreactive intervention like nitric oxide inhalation or oxygen inhalation to result in mean pulmonary artery pressure fall of equal to or more than 10 millimeters of mercury, and the mean pulmonary artery pressure must be 40 millimeters of mercury or less. So both should be there. So it should be mean pulmonary artery pressure should be less than 40 millimeters of mercury, and also there should be a fall of mean pulmonary artery pressure by equal to or more than 10 millimeters of mercury. So that will help you to diagnose vasoreactive pulmonary hypertension. And these patients respond to calcium channel blockers. And most widely used calcium channel blocker for this condition is
amlodipine.
No, nifedipine. Nifedipine is most widely used. Amlodipine also can be used, but nifedipine is the one which is most widely used and found to be most effective. Sometimes you may have to give very high doses. In one of my patients, I have given up to 80 milligrams of calcium channel blocker, nifedipine, and she responded very well to her pressure. So if you can establish that there is evidence of vasoreactive pulmonary hypertension, and this patient prognosis is much better. What is the percentage of patients who can have vasoreactive pulmonary hypertension?
3% only, sir.
Which one?
3%. Only 3%.
5 to 7%. So it's about 5 to 7%. It's very small. 5 to 7% patients can have some degree of vasoreactive pulmonary hypertension. It's definitely less than 5, maybe around 5%. That will be more correct. Okay. What are the other drugs that can be used? Rahul?
Yes, sir. Prostanoids are ambrisentan endothelin-1 receptor antagonist.
No. Go with the first one. You can have a prostacyclin modulation.
Prostacyclin modulation.
There are 3 drugs are available. One has to be given intravenously, prostanoids. Treprostinil is an inhalation. And selexipag it can be given orally. It is a prostacyclin receptor agonist. It actually stimulates the prostacyclin receptor, and with smaller dose of prostacyclin, there will be a profound effect. Selexipag can be given orally, and is an encouraging step towards the management of pulmonary arterial hypertension. What are the other groups of drugs which can be used for pulmonary hypertension treatment?
Endothelin-1 receptor antagonist, sir.
Yes.
Then phosphodiesterase 5 inhibitors like sildenafil.
Yes, and then? Anybody else? Any other group of drug?
The newer drug has come, Varsiguat, the cyclic GMP.
Yes, very good. So these are the other drugs. Endothelin-1 receptor antagonists. They are bosentan, ambrisentan, and macitentan. 5 phosphodiesterase enzyme inhibitors, sildenafil, tadalafil, and soluble guanylate cyclase stimulator, VOC-GOT. It increases the sensitivity of soluble guanylate to nitric oxide. So with a smaller quantity of nitric oxide, you will have a profound response. This is a new drug which is the VOC-GOT. Most important point is that the VOC-GOT should not be combined with
phosphodiesterase 5 inhibitors, anodonors.
Yeah, they reduce the nitric oxide, and if the sensitivity of soluble guanylate to nitric oxide is increased, there can be profound effect. It can give us to severe hypotension, and patient will be miserable. So you cannot combine VOC-GOT with 5 phosphodiesterase enzyme inhibitors. Combination treatment is the most recommended one. Best combination. You can combine with endothelin-1 receptor antagonist with either with a 5 phosphodiesterase enzyme inhibitor or VOC-GOT. This combination is probably the best one. And this also can be combined, no problems. So endothelin-1 receptor antagonist can be combined with one of these two. The prostacyclin modulators are not freely available. They are very expensive also. So at present we don't have that armamentarium. But these 3 are available to us. A combination treatment is the most ideal. Bosentan has got more toxic side effects. It is liver toxic, so you should regularly monitor cardiac liver enzymes. Ambrisentan and macitentan is more safe, and it can be used. Those patients where they are developing progressive pulmonary arterial hypertension and progressive right heart failure, you can think of an interventional treatment, atrial septostomy. Atrial septostomy, by reducing the RV load, sometimes can reduce the symptoms. But it is at a bargain that these patients can then go in for cyanosis. There are few investigational drugs, like drugs which have anti-inflammatory and antioxidative properties. And there are certain drugs which are being now developing or getting developed, targeting the immune system in patients with pulmonary hypertension. But so far, none of these drugs have been shown to be highly effective. But a lot of research is going into pulmonary arterial hypertension, and we are sure that most likely in the near future we will have a good drug which can control pulmonary arterial hypertension. What about the prognosis? There are many points which you should look at the prognosis and progression of symptoms. If the rapid progression is a bad prognostic sign. If the patient is having clinical signs of heart failure, that is a bad sign. Syncope, repeated syncope is a bad sign. WHO class, if the patient is having 3 or rather sometimes 4, bad sign. And 6-minute walk test, the distance which the patient can walk also gives you an idea. Then evidence of heart failure and echocardiography showing more of right atrial enlargement. All these are points against or rather indicate bad prognosis. So, Rahul, what do you think about the prognosis of our patient?
Sir, it looks like grey prognosis because
Grey
she's
prognosis.
having.
Why did you say that?
Because she's having enlarged right ventricle. Also, she was having symptoms of almost grade 3, grade 4.
Yes.
And echocardiography, RA area, we don't know, but.
She has got evidence of right heart failure.
Yes, she was having RV dysfunction also.
Yes, rapid progression of symptoms. The exercise tolerance is poor. We have not done NT and pro-BNP, NT-pro-BNP plasma levels. We have not done, but I am sure that it will be definitely significantly increased. All put together, she has got a bad
grey prognosis, bad prognosis.
Prognosis is bad. Okay, any doubts about the pulmonary arterial hypertension, especially primary pulmonary arterial hypertension, how to approach the case, how to decide management, and what are the drugs available, all those things. Any doubts if you have, you can ask.
Sir, good evening, sir. Mahesh here. Sir, how to start drugs in the sequence when such patient come to us?
The drugs I usually start is I start combine endothelin 1 receptor blocker plus sildenafil or tadalafil can be started. And Riociguat is little expensive, a bit expensive, so I don't start that drug initially. Very often my favorite combination is a combination of endothelin blocker. You can either use ambrisentan or macitentan combined with tadalafil. So nowadays, this combination drug is available. Ambrisentan with tadalafil, macitentan with tadalafil is available, and it can be given once a day. Tadalafil the dose, if you want to independently increase, this dose is usually 20 milligrams in the combined drug capsule, combined tablet. But if you want to increase the tadalafil dosage, it can be increased up to 40 milligrams. If the patient is not responding, and if the patient is not showing any signs of any satisfactory improvement, then I stop 5-phosphodiesterase enzyme inhibitor and change over to Riociguat. When you change over, you should have at least a gap of 36 hours with sildenafil and 40 hours with tadalafil before you start Riociguat. So combination with the endothelin receptor antagonist with the Riociguat also can be tried. At the moment, we don't have drugs where the prostacyclin modulators are not available with us, so we cannot use those drugs. My experience is with endothelin receptor antagonist and with sildenafil. That is the combination I have used maximum, and there are patients who respond reasonably well.
Sir, at which stage we can advise to patient for septal atrial septotomy?
So septotomy is actually an end-stage procedure, because if the patient pressure is not coming up, patient is having a severe right heart failure, and the patient is steadily deteriorating, then decompressing the right ventricle sometimes can reduce symptoms. So if the patient is deteriorating, even in spite of your all combination treatment, trying newer and newer drugs in adequate dosage, then you can recommend atrial septostomy. Patients who have to undergo septostomy, they may develop cyanosis, they may deteriorate, and their prognosis is very bad. Only thing is that you may be able to give them some relief for a short period.
So, any difference between only atrial septostomy and atrial flow regulators?
I could not understand your question. What do you mean by atrial flow?
In some books they given atrial septostomy, and some book given the atrial flow regulator devices.
Well, like you mean the one which blocks the regurgitation from right atrium to the IVC and SVC. The valves which regulate the, is that what you're saying?
Sir, atrial flow regulator.
I do not know what is it. Can you explain to me?
So actually it is device kept in between the interatrial septum to regulate the flow from LA to RA.
Unidirectional flow.
I do not know. I have not read about it, so I cannot answer that question. I do not know how does it regulate and what is the benefit in a patient with the primary pulmonary hypertension. I do not know. I have to verify that point. I do not know. How does it regulate the flow? What is the mechanism? What is it a valve there? Or how does it regulate the flow? And how is it implanted? How is it implanted in a patient with the intact intraatrial septum?
So it is a device which only kept just make the sure that opening is patent and between the septum, interatrial septum.
Septostomy.
You mean after the atrial septostomy, you can insert this device?
Yes, sir.
Yes, sir. It is like ASD closure device only, sir, but it is having communication between the at the center, so that it can communicate between the right and left atrium.
No, but what is the additional benefit? You are introducing a device there, and the presence of a device always can create complications. So, what is the extra benefit?
Well, because sometimes atrial septostomy can get closed, so that's why they have developed this device.
So, there is something like a ring which keep the septostomy orifice open.
Yes, sir. Yes, sir.
Yes.
Okay. I do not know whether that has been shown to have any benefit or not. I have not read that, so I do not know. Okay. Beg your pardon?
Guidelines also it has been mentioned.
The concept may be right, but I do not know whether it is really beneficial and whether there are any associated complications, because I have not practiced it and I have not read about it also.
And sir, one question, sir, when we post a patient for cardiac transplant in this case?
In these patients, cardiac transplantation is may not be of much use. You have to do a heart lung transplantation.
Yes, sir. If it is more than 8 wood units, then only. No, sir.
Yeah. Because since the patient is having pulmonary arterial hypertension, the cardiac transplantation is not enough. If you want to do, you have to do a heart plus one lung transplantation. Or the lung should be removed, at least one lung should be transplanted. Unless there is a cardiopulmonary transplantation, these patients will not be benefited. Cardiac transplantation alone is not enough.
Excuse me, sir. Sir, could you discuss transpulmonary gradient once and its significance?
Transplant, you record the mean pulmonary artery pressure, then you record the pulmonary artery diastolic pressure, and then you record the pulmonary artery wedge pressure. The pressure, mean pulmonary artery pressure minus pulmonary artery wedge pressure will give you the pressure drop. Normally, this pressure drop should be less than 12 millimeters. If the pressure drop is more than 12 millimeters, it indicates that the patient is having not only pulmonary passive pulmonary pressure elevation, but also there is some degree of pulmonary vascular reaction. Because normally what is the mean pulmonary artery pressure?
9 to 19?
Yeah, sorry, below 18. So usually it is around 14. What is the mean left atrial pressure or mean the mean pulmonary artery wedge pressure?
15.
Less than 15, around 12.
Usually less than 12, maybe usually around 8 to 11. That's usually better, around 8 or 9. So 14 or 15 minus 8 will be around
7.
7. So the difference between mean pulmonary artery pressure minus pulmonary artery pressure is usually around 7. But if it goes above 12, that obviously means there is some degree of pulmonary vascular reaction. This can also be detected by reducing the pulmonary artery bed pressure from pulmonary artery diastolic pressure. What is the normal pulmonary diastolic pressure?
7.
Maybe around 8 or maybe sometimes 10, maybe 8 or 10. And what is the left atrial pressure? Maybe 6 or 7. So the gradient between the pulmonary diastolic pressure and pulmonary artery pressure will be usually around 2 to 3, and up to 5 is normal, and when it is more than 7, it is abnormal. So by finding out the gradient between the mean pulmonary artery pressure and pulmonary artery bed pressure and pulmonary artery diastolic pressure and pulmonary artery bed pressure, we are looking at whether there is any pulmonary on top of passive elevation of the pulmonary artery pressure, whether there is any pulmonary vascular reaction. And if the upper limit is exceeded, then that usually indicates there is some degree of pulmonary vascular reaction on top of pulmonary venous passive pulmonary artery pressure elevation. When the pulmonary venous pressure goes up, there is a passive elevation of the pulmonary arterial pressure. And in a patient with pulmonary venous pressure elevation, there can be passive elevation of the pulmonary venous pressure, and on top of that, there can be vascular reaction resulting in precapillary or pulmonary arterial reaction resulting in vasoreactive pulmonary hypertension. For mitral stenosis, you can have passive elevation of the pulmonary artery pressure. You can have the reactive pulmonary artery hypertension, and you can have obligatory pulmonary artery hypertension. So we are looking at whether there is any vascular reaction which is contributing to pulmonary artery pressure.
Sir, once we get, if there is some vascular component in this, does the treatment change? Does this make a difference in the treatment in the long run?
Now, all patients with precapillary pulmonary hypertension have vascular reaction. So it is the vascular reaction which results in pulmonary hypertension in all patients with precapillary pulmonary hypertension. So we are targeting precapillary the blood vessel with the various drugs that we are giving. In a patient with group 2, that patient is having pulmonary hypertension secondary to left heart failure. If you reduce the pulmonary vasoreaction, that may aggravate the symptoms of the patient. So in patients with group 2, where the pulmonary hypertension is secondary to pulmonary left heart disease, the first thing is to treat left heart disease, and then only you should consider reducing the pulmonary precapillary pulmonary hypertension.
Thank you, sir.
There is some now extra noise coming. Is there any other doubt? Because 9 o'clock now. There are no more doubts. I think we will close the session. And what do you want next week?
Sir, coronary angiograms.
Angiogram. Okay, we'll show you some coronary as well as some angiograms, some interesting angiograms. Okay, so next week we'll have angiograms and how to interpret the angiograms. So we'll look at that. Okay, right.
Sir, some basic about PET scan and all.
PET scan, I am not an expert. I think that should be taught by somebody who is imaging specialist. PET scan, I may not be able to teach you well because I am not an expert. Basic things I can tell you, but I cannot teach you advanced things, very basic things. So what is the basis of PET scan and how to interpret? Those things can be told, but I cannot take PET scan in great depth. Okay, any other doubts? So we'll try to teach you some about angiograms, and if there is some more time, we'll take something on pressure tracing also, pressure tracing and angiogram. Okay.
Yes, sir.
Okay. Good night. Good night.
Good
Yeah,
night,
good.
sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Good night.